We're excited to be here today with Dr. Casey McCullough. Casey is one of our SUU Rural Health Scholar alums, and you're going to get to know him a little bit better today. He went to medical school at Washington University, and he'll share with you a little bit about his experiences in medical school, residency, and now in his practice environment in Blanding, Utah. We also are joined by student Zach Brown, who is a student in our program at SUU, who is also from Blanding. And so we want to welcome all of you today. And Casey Giles is our program coordinator who's going to keep us on task. And Casey, we're all in the where we can see all four. It's not the speaker mode. Do we need to change that?
Oh, fixed it. There we go.
Oh, good. So hopefully, well, for some reason, we're still seeing I'm seeing all four. Is that still good?
Yeah, it's fixed. It's good on my end. So it'll be
good. We just want to make sure we've got a good video going. Well, Casey, would you maybe tell us a little bit about yourself, your background, and how your practice is going now in Blanding, maybe just as an introduction?
Sure. So as far as background goes, I grew up in a small town in Panguitch, Utah, and then went to undergrad over there at Cedar City, SUU. Following that, went to medical school in Washington University, as you said, and then down to residency in Texas, at Texas A&M residency program there. Following residency, I went directly over to Blanding. That was my first practice place, and it's actually been where I've been since for now about 7, 8 years, somewhere around that. So yeah, my practice basically is a rural, I'd call it a traditional full scope family practice, basically practice pattern. So I see patients in the clinic, I round on patients in the hospital, I do ER call, and I deliver babies. So we kind of a full scope type thing. I used to do some scopes. I was trained in that and doing that, and I did some scopes here for a little while, but then we got a general surgeon here that did a lot of the scopes. And so I kind of dropped that out of my practice so that the general surgeon could have that patient base. So, but yeah, so that's kind of what I've been doing, and I've been doing it for the whole 8 years that I've been here, and it's been a great experience. So.
That's fantastic. So when you first decided to practice in Blanding, and tell us a little bit about that. How did you feel coming right out of residency? Did you feel prepared? Were you a little nervous taking on that? I know you have colleagues down there to assist, but share a little bit about that experience with us.
Sure. Yeah. So obviously, definitely a little bit nervous. I mean, anytime you're moving from residency where you do have a lot of oversight from your attending physicians who kind of show you if you have any problems or concerns, to a situation where you don't necessarily have that oversight, you're going to be a little bit concerned. I felt like I was very prepared for certain things. Obstetrics, my residency did a great job of training me in obstetrics. I felt very, very comfortable with the obstetrics, except for the situation that in a small town, you're always going to be a little bit uncomfortable with obstetrics because there's always a chance that things could go really wrong. And small towns don't have all the resources that the big hospitals do. And so you always worry about some of those things that happen. But I felt pretty prepared there. Clinic, I had no concerns about. Even hospital medicine, I didn't have a whole lot of concerns about. ER, I was a little bit worried, I'll be honest. My residency, I felt like I got good experience in the ER, but I didn't see everything. And I knew that in a small town like this, anything could come in the door, and I'm the only one there. And it was a little bit, I think my first few ER calls, I was pretty nervous. And after doing it for a while, though, I got used to it. And I also realized that I did have colleagues that I could call upon that were oftentimes available to at least give me some phone consultation and give me some direction. And so after doing it for about a year, I felt a lot more comfortable and was doing okay with it. So yeah, but definitely the change there was definitely a little bit concerning, but I felt like I had good training. I really did. My residency did a great job they were kind of focused on rural medicine, and they did a great job of making sure that I felt like I had those experiences going into it. So it was.
So Casey, I always brag about you. Casey was one of our superstars, and I always joke his MCAT score was one of the top scores we've ever had out of SUU. And he
Oh.
to a very prestigious medical school. In fact, I would encourage our students to dream big. And, Casey went to Washington University. Would you share a little bit about how you ended up choosing family practice? Because Casey, I know you could have chose any specialty in the world and done it. And I just sing your praises that you chose family practice. Coming back to Blanding, and I'm thinking you were on loan repayment?
I did. Yep, I did do the loan repayment. Yep.
Share a little bit about that scenario and how you ended up making those choices.
Okay, definitely. It was kind of an interesting the way it played out. I was planning on going to University of Utah the whole time I was in pre-med. I mean, that was kind of my goal and my dream, I guess, just because it was my state school, and I was hoping to get in-state tuition. When I applied for a bunch of different medical schools, though, and I got accepted for an interview at Washington University. I went out there and checked it out, and I loved it out there. It was a great experience, and my interview at the U of U just didn't go quite as well. Like I didn't enjoy it as much. I got accepted to both places, and it was a really hard decision to turn down the U, because that's what I was always trying to do. But I'm glad I did. I went out to Washington University and I had a wonderful education. The interesting thing about Washington University, though, is the fact that it is very specialty driven, because it is kind of one of the top medical schools. Very high, a lot of research that's going on there, so it's very specialty driven. So after about a year of being there, I found out that they don't even have a family medicine program at Washington University. So, and so when I told them I was interested in family medicine, they did find a family medicine doctor that could be my mentor, but he was like the only family medicine doctor on staff. And he was actually doing more informatics stuff than he was actually practicing medicine. So he was a great guy, and I really enjoyed talking to him, and he gave me some good pointers and stuff like that. But it was an interesting situation. So I got a great education, had a wonderful experience in my clinicals. I did get to do some family medicine away rotations.
Just checking, who froze?
I think Dr. McCullough froze. At least that's what I'm seeing on my end.
Yeah, I think Dr. McCullough froze.
He's in Blanding. Rural.
But I did struggle with what I wanted to do. I was deciding what.
Uh-oh, okay.
Sorry about that.
That's
I don't know
okay.
what happened.
That's all right. I think we got the gist of that. And so share about your loan repayment a little bit. Are you on
Okay, yeah.
federal
So-
loan repayment, state loan repayment?
Federal loan payment. I went through the National Health Service Corps, and I just applied after residency. I just applied, and because Blanding is a pretty high on the list, I got that pretty easily, apparently.
Awesome.
And so that worked out pretty smoothly. The one thing about federal loan payment, you have to put in a lot of hours at the actual facility, and you have to document it. So the interesting thing was that my company was giving me a lot more time off than what the loan repayment would allow me to take off. So I had to like build up my time there and stuff like that. So, but it went fine, and it was very helpful to pay it off. I mean, I actually can say that I've actually been able to pay it all off now. So it's been great.
Yay, congratulations.
Yeah.
Zach, do you have some questions for Dr. McCullough? And I just love the fact that you two know each other from Blanding. And tell us a little bit about yourself, Zach.
So I'm also from Blanding, Utah, and I'm here at SUU in my sophomore year, majoring in biology and minoring in chemistry, hoping to go pre-med. And that's kind of the idea that I had, as well as family practice medicine. I had a lot of questions about how did you pay for medical school, which we already covered that, and how you ended up in Blanding. Would you say that loan repayment program was one of the reasons you went to Blanding, what like ended you up back in Blanding versus practicing family medicine in an urban environment versus rural?
So I think actually loan repayment had nothing to do with it, to tell you the truth. Just because I had no desire to practice family medicine in an urban center area. Just because the difference in what family medicine is in those two different situations. In urban areas, you're in family medicine, you're much restricted in what your scope can be. You do a lot more in clinic stuff, and you're not allowed to do as much in the hospital. For instance, I mean, most big hospitals in urban areas would not allow a family medicine doctor to work in the ER because they require ER trained physicians. So you'd have to go to an ER residency to be able to work in a big city in the ER. So it's only usually in smaller areas where family medicine doctors can work in the ER. So same thing with OB. Sometimes some of these bigger hospitals, as a family medicine doctor, you may struggle to be able to do, you can do OB, but sometimes you can't do surgical OB. You can't do the actual C-sections sometimes in these bigger hospitals. And every hospital is a little bit different, but some hospitals kind of restrict your, say if you're not OB trained, and like I said, it depends on the politics of the hospital. And a lot of it has to do with the OB-GYN department. They say, well, if you're not OB-GYN trained, then you can't do C-sections. Or you have to show that you've done a ton of C-sections in the past to be able to show it. So I didn't want to deal with those politics. And so I just wanted to go to a small rural area. So yeah, the loan repayment didn't really have anything to do with it. I wanted to be in a rural area because that's where I could practice what kind of medicine that I wanted to practice. So, but it definitely was a nice perk also. So, and I think a lot of times rural places, like rural facilities get kind of, because a lot of times I think family our doctors come to the rural facilities just for the loan repayment, and then as soon as loan repayment's finished, they leave. And so I think a lot of rural facilities are thinking that that's sometimes what people are doing. And I actually think some of the people here thought maybe that's what I was doing because I didn't have any ties to Blanding, and they were kind of like, "What's he doing here?" And so when that was kind of all up and done, I still stayed around. I think they were a little bit surprised because they never really actually talked to me about it that much. They just kind of assumed that's kind of where it was. But so no, it wasn't loan repayment. It was mostly because I was looking for rural, and when I got out of residency, this is one of the places that had an opening and was advertising. My hometown that I was planning on going back to didn't have an opening when I got out of residency, and so I didn't go there. And actually, I'm glad for that. I think some of the benefits of being not in my hometown are huge. I didn't have to deal with the fact that people knew about what kind of a punk I was as a child, and dealing with them as a physician in a different role. So there are some benefits to that, but I have loved Blanding, and my family has made roots, and so I don't see no reason why I would leave, and barring some crazy incidents or something else that would pull me away. So, but
awesome. At what point in time was it that you decided that you wanted to not only practice family medicine but also practice rural? Was it early on when you were a child, or was it later on in med school when you decided you would try some things and figure that out? At what point in time did you make that decision?
So it started out in the beginning. My dad was a physician's assistant in Panguitch, and so I watched him work the hospital and the clinic and all that kind of stuff. And I also watched him have to do more call because the doctors wouldn't stay around. They'd come in for about a year or two, and then usually the doctors loved it, but the wives had a hard time with the small town situation, and so they would leave within a couple of years. And so there was, in Panguitch, when I was growing up, there was always a need for more doctors. They just never had enough, and so that's where it started. Is that I'm going to go to medical school, I'm going to become a doctor, and then I'm going to come back to a hometown. When I was in residency, I did see a lot of other cool things that were not rural medicine. Okay, and it was tempting to go to do some of those things, but when it came down to the decision, I wanted to live in a small town, and I really loved the scope of rural family medicine. The fact that I can do a lot of things. It was really kind of a funny situation when I was in medical school, when people would ask me, "What do you want to do?" And I said, "Family medicine." They say, "Oh, you just want to be in a clinic all the time?" They were kind of surprised by it. And then when I told them, no, I want to deliver babies, do C-sections, do scopes, do stuff like that, they said, "You can't do that." Because in a big city, they don't understand that. They don't, that's all split up among other different specialties, so they don't understand that's even possible. When I explain that to them, they get kind of like, oh, really? You know? So, and I always kind of felt like that was being a real doctor. I'll be honest. Like, I mean, no offense to any other doctor, but being able to do kind of the full scope was just always something I've always kind of dreamed of. So it wasn't an easy decision because there are some downsides to it. It's very time consuming, but I haven't regretted the choice. So.
Casey, would you tell us a little bit about your patient population? You're in Blanding, you're in the heart of the Navajo Reservation. You have some interesting patients that you're working with. You share a little bit about some of the challenges that face some of your patients, both living in a rural community, very isolated, as well as some of the challenges that the diversity creates.
Definitely. Yeah, so when I first started working here, I actually was working in Montezuma Creek. So I lived in Blanding and I worked in the hospital in Blanding. My clinic was actually down in Montezuma Creek, which is actually on the reservation. And so the majority of my clinic patient population was Navajo. And definitely some unique challenges there. There's especially with the older generation of the Navajo, because a lot of them were Navajo speaking only. So communication with them was sometimes very difficult. We'd have to have somebody translate for us. And it would take more time to you think of a 15-minute appointment, including translation in there, and also just the difficulties of culture barriers. It was very challenging, actually. And especially so that's one of the things. Language barriers were challenged. Culturally, there's definitely some challenges there to help your patients understand kind of why you're making some of the decisions you're making about their medications and about why you're doing those kind of things was difficult sometimes to translate that. One of the big things that I learned, and nobody actually taught me this until like I've been here for like a couple of years, that there's definitely some cultural issues. For instance, in the Navajo culture, it's not considered okay to tell a patient, hey, if you don't take your medicine for your diabetes, you could develop kidney failure, okay? Because if you say it like that, in their culture, they are believing you are jinxing them or wishing this upon them. And so I actually had many patients who got very angry at me, and I didn't understand what was going on and why I had them getting angry at me until finally somebody else down here explained that cultural difference to me. And then I was able to make some changes in the way I spoke with my patients and stuff like that. So yeah, definitely some cultural difficulties that makes it difficult. I mean, with this, with the COVID, we had a huge outbreak down here on the Navajo Reservation. And a lot of that's to do with the fact that there's a lot of families living in the same small cramped spaces. And so that was difficult, but we were able to do a lot of things with some funding that was given to us, donated to us to help some of the families kind of separate when there were people who were positive for COVID. And a lot of our people down here don't have water and electricity sometimes. And so when you're saying, you need to be on a CPAP, they say, well, how am I going to do that, doctor? I don't have any electricity. So we have to be very creative. And sometimes we find ways to do like solar powered kind of type things. And we work around some of those issues. So yeah, definitely a lot of differences that you would not have expected to have to deal with as a physician in the United States. So, but yeah.
Zach, any questions about how to prepare for medical school?
Yeah, I could ask lots of questions, depending on whatever you wanted me to ask, but I, just thinking of me in my steps with, processes ahead of me, like application, and then medical school, and then processes like the match, like what would you, say to somebody in my shoes, best practices for, going about this process of applying to medical schools, and everything that goes along with it?
Yeah, I mean, definitely using the resources that are available to you is very important. Thanks to Rita and the Rural Health Scholar Program. I mean, they kind of help you understand what medical schools are looking for, and help you to kind of know what you should be doing to kind of do that. One suggestion I would give you is sometimes when you're trying to apply for medical school, you're doing a lot of these things to kind of just, I guess what I'll say, pad your resume. Try to avoid doing things just to pad your resume, and think about the reason why the medical school would want you to be involved in these different things and be able to show that and make it and use that as a way to build who you are as a person. I mean, I remember some of the things I did, like working in the women's shelter there at SUU, to get experience there. I mean, it was, I think initially I did it just as kind of a pad my resume type of thing, but I mean, being there and seeing some of these challenges that these families are going through was such an eye-opening experience for me. And so it's those kind of things that I think, yeah, they're things that you're doing so you can get into medical school, but there are things that you're doing to really make you a better person so that you can be a better doctor when you are in medical school and in your future career. So think of them as those kind of things, and really put your heart into them, and you really will become the kind of person that you want to be. So and enjoy the process, Zach. I mean, one of the things that I think sometimes medical students get into the rut of is like, okay, I just want to get through this. I'm just trying to get to become a doctor, and this is just a hurdle I have to get through. But there are so many cool things that are going on through your medical education that, there are going to be times they're going to be rough. Don't get me wrong. I mean, you're going to struggle. You're going to have a hard time, but try to enjoy the actual experience, because if you it's not just something to get through. It's part of that building experience. And if you focus on that and enjoy those experiences and enjoy meeting those people that you're learning from, and you're getting the information to become a better doctor, you really have a better time, and it won't be quite as a drudgery that sometimes people kind of paint it to be. So.
Awesome. Thanks, Dr. McCullough. What would you say was your difference maker, per se, to be able to get into the not only the med school that you were dreaming to go to of the U of U, as well as to other prestigious medical schools? Was it your high MCAT score, or was it those experiences that you had, or was it something else that you felt like helped you get in the most?
Definitely the high MCAT score helps. I mean, there's no doubt. Don't let anybody ever paint a different picture. I mean, because we have to be honest about this. The MCAT scores is sometimes just that first hurdle that makes you make that next cut, basically, to even give you an opportunity to show them who you are. Okay. So yeah, I mean, take the MCAT seriously, study for it, try to do your best on it, because those MCAT scores are going to definitely, I don't think I would have gotten into Washington University without the good MCAT score. I mean, I don't know that I would have even gotten an interview there without that MCAT score, because Washington University has if you look at the MCAT scores of all their accepting students, they're all pretty dang high. I mean, you have to actually reach that bar before you can get into it. Now, U of U, not as much. That you can get into U of U without as high of a MCAT score. And U of U is a great program to get into. So I don't think everything leans on MCAT scores. So don't think that that's the only way to get into medical school is get a good MCAT score. But I do think once you've reached that bar, then you can show them who you are through your experiences. And then on the interview, being able to just go up there and just be yourself and share with them who what you want and what your dreams are and those kind of things. And I think those will be beneficial, but definitely the MCAT score helps. There's no doubt.
Yeah.
So.
What did you have for patient exposure in your undergraduate experience? How much patient exposure did you do?
I had quite a bit, mainly because of my upbringing. I mean, my dad was a PA, and back in those days, there wasn't as many HIPAA restrictions. So I even as a small child, I remember following my dad to the hospital sometimes and actually watching him do a lot of the things he did. But then I also worked as an EMT. Starting at 18, I got my emergency medicine technician license, and I was able to do that on the volunteer service back at home for about a year before I went over to school. Then once I was at school, I did get on. I was lucky enough to get on the Iron County ambulance service, and so during undergrad, I was actually doing EMT, which was actually also a great job for a undergrad, because there are many times that we were sitting in the station waiting for a call, and I could work on homework. When the call came, then of course I put the homework down and went on the call and learned there and stuff like that. So I had that exposure. I also had some exposure on the fire line. I worked as a wildland firefighter during the summers, and was also an EMT in that instance too. So I had some patient exposure through that. And then of course I did some job shadowing, so I had some patient exposure through that. So quite a bit of patient exposure, and even some that you may not be able to get. I mean, I feel like I was very, I don't know, for better terms, lucky or blessed in the sense that I was able to get those opportunities, because I think sometimes those are hard to come by when there's a lot of people trying to get some of those same opportunities. So, but it was good experience.
So I'm kind of curious, especially since you work with a lot of different people, you do a lot of different things, like you said, because you are living in a rural area as a family practice doctor. I'm wanting to know about some of maybe the most interesting cases that you've had.
Yeah. Good question. So interesting cases can be divided up into a lot of different things. I think the ones that stand out in my mind are probably the ones that I probably was the most, I don't know how to say that, kind of stressed, I guess, or even brought to that brink of, concern because of things going on. So some different things that kind of would occur there. I mean, I had patients I had a patient that came in that was a peritoneal dialysis patient that came to the ER with complaints of being kind of dizzy. And so we, blood pressures were slightly low. And this patient, I assumed it was just because they maybe over-dialyzed, and so they're a little bit low on their fluid and stuff like that. But by the time we got her back there, I listened to her heart, and I could barely hear her heart. And I was like, what's going on? And we get her up for standing up. We did an EKG on her, and the EKG was the leads showed that her signal was very, very small. And so that's when it started all coming to my picture. I was like, oh, this lady may have a pericardial effusion. So we did an ultrasound on the heart. And of course, I just grabbed the ultrasound and put it on there, and I could see a huge amount of fluid around this lady's heart. So she actually had a cardiac tamponade in a situation that wasn't actually a trauma. Usually you see that in a trauma situation. So she had pericardial tamponade there. And her blood pressures were really low. And actually, this is one of the first experiences where I was kind of stuck in a position where I didn't have a lot of experience with this, and I had to kind of deal with it. And that's because I'd never stuck a needle in somebody's pericardium, the sac around the patient's heart. I'd never had the opportunity to do that because it just doesn't happen very often. So throughout my training, I'd been trained on how to do it, but actually doing it, never had that opportunity. Now I was stuck in the situation where I kind of had to do it for this patient's to be able to survive. So so that was a very stressful situation. We got the ultrasound out. We did it. We pulled the fluid off of her heart. Her blood pressure came up. She was doing great. We got her on a helicopter. The fluid filled back up. She actually coded on the helicopter. They had to land in Price, and they had to pull out more fluid out and got her heart back, and then got her back on the helicopter and flew her over to Utah Valley, where the cardiothoracic surgeon could do a window to get the fluid out of the heart a little bit longer. So that was a little bit of a kind of a stressful situation. Other situations where you know, kind of interesting patients would be, I mean, we've had, I've actually seen some things that I thought would you would never actually see anymore. And what I mean by that is that seen a couple gonococcal arthritis that came in that was just something that was kind of strange that you learn about in medical school, but you never actually saw in medical school or in residency. And then all of a sudden it pops up over here. And I think a lot of it probably because of the reservation exposure that I'm exposed to, some of these things kind of occur. Trying to think, but I mean, those are some of I mean, there's definitely many other ones I could go through, but a lot of the times I think it's the ones that are most interesting to me are the ones where it's something that I haven't been quite prepared for, because you can't prepare for everything unless you've, you know, been in this field for your whole life. So you always be running into those situations no matter where you are in your career. So, but yeah.
Awesome. Thank you.
You're welcome.
Let's see. I'm going down the list to see what other questions I think I'd like to ask. Let's see.
I have a question real quick, if
Yeah.
you're open. So I feel like as I've talked to you and other doctors, because I've talked to quite a few in different communities, and I think I've gotten an okay perception on what rural healthcare is, but how do you see it changing in the time that I have from now until, you know, until I can start practicing in the next, you know, 5 to 10 years ish?
Yeah, that's a good question. And it's kind of a weird thing being in rural medicine. Rural medicine's a little, you know, with the changes in healthcare of trying to go to like fee for service to managed care, or those kind of changes that have kind of been been going through healthcare. I haven't seen a lot of those here in rural medicine, and I don't know if it's because I think a lot of it's to do with the fact that we have some different agreements when it comes to, like, for instance, our hospital is a critical access hospital. So our hospital doesn't have to follow all the rules of Medicare that some of the bigger hospitals have to follow, because they understand that we don't have the resources that some of those bigger hospitals have. We also don't have the numbers. Like you know, like those other hospitals are required to look and see, you know, like keep track of the complication rates and figure out how you can kind of fix those complication rates. Well, when you only have like 2 patients a year that have that issue, it's kind of hard to really get good data to know what those complications rate do. So we do do a lot of, I see one of the things that's definitely going to change is a lot of virtual, especially for rural medicine, is a lot more virtual things and being in tied. So we have a lot of agreements with the University of Utah right now, where we're doing a lot of our what we call quality control measures. So to improve our quality, we're doing it in conjunction with other small hospitals that are all affiliates with the University of Utah. So we kind of combine all of our numbers together and help make a better data to kind of help us make change, to drive changes, basically, to improve our care. So a lot of more collaboration with bigger hospitals. In a way, I mean, so right now, one of the things that we got established since I've been here, actually 2 things we got established since I've been here. When I first got here, we didn't keep any ICU patients at all. And mainly that was just because we don't have an ICU, we don't have respiratory therapists. Our nurses were very uncomfortable with the idea of keeping some of these patients. But we actually had situations where we had patients that would come into the ER that were very, very sick, that needed to be on pressors, that needed to have ICU care. And then also situations where we couldn't get those people out. I mean, I had, within like 2 months of being here, I had a patient who came in was very sick that needed to be in ICU that I wish I could have sent out, but I couldn't for 3 days because we were in the middle of a snowstorm. And getting those patients on a helicopter or an airplane was just not an option. And our crews here, as far as ground crews, do not have the training to take care of ICU type patients. And so they couldn't take them even ground level. So I had to hold on to this patient for like 3 days when probably wasn't the best place to have it. Now, luckily, I had some ICU experience in my residency, so I felt like I could do it. And but we were able to get something set up where we have a tele ICU situation now, where now we have an ICU doctor who can chime into the computer and look at our patient, and they can see all of our labs and our vitals and all that kind of stuff, and they can help us make decisions. And so we're able to keep a lot more patients here that are more critical, because and actually that's very beneficial to the patients. I mean, a lot of these patients hate to get flown out. I mean, they live here. Their family's here, they get flown out, their family has to drive all the way up to Salt Lake to see them. Then they have to figure out how to get back after when they're still kind of sick, you know. So they love to stay here. And if we can keep them here, it really is a huge benefit. We did that with tele ICU, and we actually now have a tele NICU situation too, where if we have a baby who comes out who's not doing quite as well as we hope, and we can get on the computer and talk with a NICU up at the university, actually they're at Intermountain. And we just talk with them, and they help us kind of decide, could we manage them here? You know, because could they stay here for a little bit longer, or is it bad enough we have to get them to a NICU, and then they help us with those coordinations like that. So I think there'll be a lot more tele visits to get us to be able to connect patients with specialists without having to have the physical distance traveled. It's really hard for patients to do. Both financially and just time-wise. So that's a huge change. As far as the other changes, yeah, I haven't seen a lot of it coming through down to us because I think we have a lot of exceptions because we're such small. I think it will drizzle down to us. So I think you will have to understand there'll be some of those quality measures that will depend on that your reimbursement will depend on. I think that will get to the fruition once you're out of medical school. And so understanding how that kind of works, I think would be important. So. But that's not always a bad thing. I mean, there's definitely downsides to the fee-for-service system that we've been under for so many years. I mean, the fact that your company makes you see as many patients as possible in a short amount of time definitely has downsides for the physician, because you don't feel like you're giving your patients the kind of care you want to give them. So if you can change the reimbursement to where it is based on getting them better care, then you may actually be able to feel like you're being a better doctor. So there's going to be pluses and minuses to both sides. I think it's just going to be something you have to kind of figure out how to navigate. So.
Okay, so many of our viewers may want to know, who is your actual employer? And,
yeah.
Is it the hospital? Is it the clinic? Is it and then what other roles have you taken in the community where you have become a leader in the healthcare community?
Yeah, definitely. So the way my practice is set up, I'm actually employed by a company called Utah Navajo Health Systems. It's a nonprofit company that was basically set up by the Navajo people down in Montezuma Creek area. And so I am basically their employee. I get paid my salary through them. And so that's basically for my clinical work, basically my 36 to 40 hours a week that I spend in the clinic. On top of that, they contract me out to the local hospital. It's called Blue Mountain Hospital, to provide ER services. So I work, usually I'm on call one weekday a month for 24 hours. And then every fifth weekend, I'm on the whole weekend. So, in those situations, they pay us a kind of a contracted rate to be in the ER there, and the same thing with any of the inpatient stuff that we do in the hospital. We get a contracted rate for that kind of thing. So basically, the hospital, I'm kind of a contracted employee through the hospital, but and so I get paid that way for that. So that's kind of the way my practice is set up. As far as other things that I've done, within a couple of years of being here, I got put in as the medical staff president at the hospital. It's a small hospital, and so there's not a lot of us for that role to go around to. So I knew I was going to have to do it at some point. But just getting put in that position, I've actually stayed in that position. Nobody else has been willing to take it over. So I've been doing that for the last 5 years. So I'm kind of considered the CMO of the hospital too. So that's kind of my main leadership role. And I do a lot of that. That's how I got set up the tele-ICU and the tele-NICU and the collaborations we have with the University of Utah. I go up there quite, probably at least once a year to do a conference with them to kind of talk about what are the collaborations we can do and stuff like that. So I'm involved in some of that, the policy making within the hospital. I do a lot of, we make policies in the hospital. We make some changes. I also deal with, any of the issues that come up with the medical staff, which sometimes can be very tiring, but it's I enjoy the leadership side though. I wish I had more dedicated time to it, but that's just kind of the way things go. So.
That's great. Zach, Casey, any other questions that you've got for Dr. McCullough?
Sure. I was just wondering, what on the daily basis do you look forward to the most, and what on a daily basis do you, maybe dread or not look forward to the most every day as you are practicing?
Yeah, I think the things I enjoy the most, I think, are usually just seeing the patients that I've kind of established a lot of rapport with, but also like even seeing a lot of the newborn babies that come in. I mean, those are kind of a lot of fun. I mean, I deliver babies in the hospital, and then they come in the clinic and see me, and I get to see that continuity of care, and then I get to see those kids kind of grow up. Each, for the other well child checks. And so, I mean, those are probably my most rewarding visits, I feel like. Although recently I started doing some buprenorphine prescribing too, which I'll be honest, initially I was very hesitant to get into that. But our community really needed it. And so I got the training for that. And I've noticed that I've enjoyed that a lot more than I thought I would. I'm making a huge benefit in a lot of these patients' lives. I've seen them go from very non-functioning individuals to the individuals who are holding down jobs and having a great family life. And I mean, their lives are just turning around in ways that are quite drastic to see those changes and stuff. And so that's been a very enjoyable part. As far as my thing that I least enjoy, I mean, obviously the documentation is always something that I wish I could just do without. I wish there was some way you could just tie your brain to the computer so it just automatically went there. Because I do have to sometimes catch up on that after work, and that's kind of draining a little bit. And the patients that are probably the most draining too are going to be your chronic pain patients. I think most doctors kind of feel that same way. Chronic pain is a difficult thing to deal with. And those patients are always going to have a little bit of a drain on your mental and emotional capacity. So, but they also can be very rewarding sometimes. So, because you can develop a very strong relationship with them because you see them much more frequently sometimes, and so that can be rewarding too. But those are the things I think from day to day that I enjoy and despise, I guess.
Well, good stuff. Well, we want to be conscientious of your time and really thank you for doing this with us. Just a shout out to Dr. McCullough's father, who was on our founding board for our Southern Utah AHEC Center. And, we're doing this under the auspices of our Utah AHEC program. So kudos to your dad. He was an amazing man. And
he was an amazing man. Thank you.
I learned an awful lot from him, and it was to get to know him and to see you take on this role in planning has just been full circle. And we're so very proud of the work that you are doing out there and the time you're taking to share with some of our younger students. Any other last words that you might have for students heading into this career?
No. Well, let me say one thing. I think this is a great opportunity for you to kind of learn what medicine is. And unfortunately with the COVID, hopefully it'll get to the point where you can actually go in and do some shadowing. Because it's a good idea to understand what medicine is. Because medicine is definitely one of those things that can be a very rewarding career. if you enjoy what you're going to be doing, being with patients, helping them out, seeing their lives improve, and just having that experience with them. Whereas it could also be a career that can be very hard to deal with if you get into the burnout side of things, and if it's not something you enjoy, and I guess if you're going into it for the wrong reasons. And not to say there's, obviously the financial reason is not necessarily a wrong reason. There's benefits from a finance standpoint, that this is a good career that pays well. But if it's the only reason you want to do this kind of thing, you're going to burn out. And I do have some colleagues who right now are struggling very hard with what to do with their lives because they just do not like what they're doing. And they keep trying different things, and if they could get out of it, I think they probably would. It's just very difficult that when that's what you've spent all your life training to do, you don't have a lot of other skills and stuff like that to make yourself available to other options. So I guess doing some good shadowing and understanding what the career is, what it entails, and making sure that it's something you want to do for multiple reasons. So.
Great.